Welcome to the EAU podcast.
Dear colleagues, thank you very much for joining us. Today we're going to discuss about very important work that just came out, and we're going to discuss about the PROTEUS trial. I'm Dr. Giancarlo Marra, academic urologist working in Turin, Italy, and today I have the pleasure to welcome with us Professor Mary-Ellen Taplin, who's the PI of the PROTEUS trial from Dana Farber Cancer Institute and Harvard Medical School. Welcome with us.
Thank you very much.
I think we can start. We can try to get some kind of historical background instead of going right into discussion. We are talking about high-risk disease, about high-risk prostate cancer. You actually already pioneered, I saw the field because you were already working in the field of perioperative treatment some years ago, I think more than 10. You published on JCO, on abiraterone, together with surgery. So can you briefly summarize what is the rationale behind the PROTEUS study and what you think is better to highlight about its background and where it's located?
Sure. As prostate cancer became better classified into low, intermediate, and high risk, we've realized that the high-risk patients really had suboptimal cure rates with standard of care. This is going back 20 years or more. And so using the concept that patients relapse after prostatectomy primarily because of microscopic systemic disease, coupled with the fact that many other cancers have improved outcomes combining systemic therapy with surgery, we started to investigate the use of androgen receptor pathway inhibitors for about 6 months prior to prostatectomy. And you're right, we started with an abiraterone trial. Key to that trial was doing a prostate biopsy at 3 months and measuring the androgens in the pathway, the androgens and androgen metabolites. And we showed that abiraterone was really hitting its target in the tissues better than ADT. And so over the course of many years, we looked at various combinations of ARPI, and that set the stage for the PROTEUS trial. We were able to do analyses and show that major pathologic responses correlated with freedom from PSA failure and subsequently freedom from metastasis. So that those data gave Johnson & Johnson the courage, if you will, to launch the PROTEUS trial.
In PROTEUS, it was a huge study. You randomized more than 2,500 patients from 184 centers, 18 countries, many involved. About the patients, they were randomized, of course, to one arm in which it was surgery plus ADT plus APA, and the other arm in which instead of APA there was placebo. The patients were all high-risk patients according mainly to the NCCN definition. So around 40% also had a PSA greater than 20. About 1 in 3 was CT3 disease or higher. I would say, if I remember correctly, 3% were CT4, approximately 10% CN1, and the vast majority, which makes it a trial in which it was strong, the pathology high-risk driven component, 95% of patients were grade group 4 or 5. My first question is, do you think this population with these features actually well represents the patient we see at MDMs or in our clinics every day, or do you think is a bit more selected subgroup towards high-risk disease within, of course, the high-risk context?
Great question. We intentionally made the eligibility to skew for more than just a little bit of Gleason 8 tumor, if you will, because the primary endpoint was metastasis-free survival. For the trial to be successful, we had to be able to measure metastasis-free survival in a reasonable time period. As it took 7 years. So the eligibility is skewed to, high volume, high risk. For instance, if you had a collection of Gleason 6s and 7, you needed 6 cores. And if there was a collection of Gleason 7 and 8 tumors and the PSA was over 20, then one only needed 3 cores. If the patient had a Gleason 9 or 10 tumor, then only 1 core was needed. The eligibility was skewed towards having patients at high risk for relapse. So yes, that will be a subset of all high-risk patients.
Great, which I think it actually makes sense, because even though you selected a subgroup of skewed toward more very high risk, some said maybe even patients with more high risk should have been selected because of the time you need to get events, which is actually something good for us, because it means we're making a great job, because we are prolonging survival. And in the trial, actually, it was permitted to give radiation and or additional treatment based on what was the clinical practice at the different centers. And I think this was also maybe one of the reasons that made you choose patients with a higher risk, because we now know those treatments increase survival. And I think we will come back on this point a bit later on. Then let's move to what are the trial results. I won't anticipate them. I will let you disclose what are the results, as you already did. You selected a dual primary endpoints. One was pathological and one other was about METs, so metastasis-free survival. Would you like to tell us why you decided on these two with dual primary endpoint, and then tell us what were the main results, the main findings?
We chose a dual primary endpoint of an early readout, which we've termed major pathologic response, and a later endpoint, metastasis-free survival, because of course, in the US, the FDA requires, metastasis-free survival, which has been validated to correlate with overall survival. Our hope would be eventually that we would be able to validate that a major pathologic response correlates with MFS. So future trials could read out, earlier than 6 or 7 years. So the results for the apalutamide and ADT compared to the placebo and ADT control were positive for both primary endpoints. So there was a almost 10-fold improvement in major pathologic response measured by having no tumor or less than 5 millimeters of tumor. And there was a investigational response of looking at major pathologic response by what's called residual cancer burden, in which a major pathologic response is defined as having less than 0.25 cubic centimeters of residual tumor. Residual cancer burden takes into account cellularity as well as the size of the residual disease. And that was also positive. And there were more. There were 30% of patients, as opposed to 10%, had major pathologic response when measured by RCB. So I think that's a very promising endpoint for future trials in terms of the pathology response. And then MFS was measured by blinded central review and included an assessment of conventional imaging, PSMA PET, and survival. And when there was a 20% improvement for the apalutamide ADT, a exploratory endpoint was investigator-assessed MFS, which I've come to appreciate more and feel that it may be a better assessment of response, because the investigators have all the data, PSAs, all the scans, clinical data, and assess recurrence, whereas the blinded central reviewers only are looking at a scan in isolation. If they're looking at a PET scan, they have the previous PET scan, but no conventional imaging, no PSA, and so forth. So there was a bigger improvement with investigator-assessed MFS. It was a hazard ratio of 0.74, a 26% improvement in investigator-assessed MFS. So those were the two primary endpoints. They were supported by a series of secondary endpoints, including event-free survival and time to first subsequent therapy, which showed almost a 3-year improvement in time to second therapy.
Okay, thank you. It is clear that besides pathological endpoint, and this insight is very interesting, because many other trials were able to show an improvement in the pathological response, but were not able to show an improvement in metastasis-free survival. So it would be great to be able to link the two. Besides the primary endpoint, a really important aspect is that, of course, now we are increasing life expectancy, but luckily we're also focusing on what it is quality of life. So you found an improvement of 20% in terms of METs, but the absolute improvement was a bit more modest, was about more or less 5%. On the other hand, of course, by increasing and intensifying treatment, there is also some toxicity. We have to recall the control arm was not the standard of care, because the standard of care currently is surgery, but ADT. So also in this setting, we have more toxicity compared to radical prostatectomy alone. And the toxicity, besides being more or less similar between the groups, which shows apalutamide as a good safety profile, was still to be noted because there was more or less up to 39% of adverse events, although the main ones were rash. There was some kind of treatment discontinuation, and I think more or less 1 in 5 men in both arms did not recover from testosterone. So the trade-off of 5% has to be balanced with some toxicity. And my first question is, clinically, do you believe this is meaningful in terms of difference in metastasis-free survival? And do you think this justifies the use of perioperative apalutamide? And of course, if not in all patients, did you identify any specific subsets of patients in which this should be performed?
All great questions. Given that these patients are so high risk and what turns out in often cases to be lifelong, intermittent, and then continuous therapy, I do think that a 20 to 26% reduction in metastasis or death is significant. If I was in those shoes and had one of these aggressive prostate cancers, I would want that type of benefit. I always try to ask myself that. So the toxicity does have to be weighed for all of our therapies: surgery individually, radiation individually, ADT individually, and the addition of an androgen receptor pathway inhibitor like apalutamide. I would say the data from the PROTEUS regimen is not trying to replace any standard of care option. It's adding an additional option to the table. And then we as clinicians need to weigh the pros and cons. You know, if you start with surgery alone and there's an 80% chance that you're going to end up with salvage radiation and hormones, you know, what is the effect of what I call double local therapy on urinary incontinence, per se? What are the trade-offs of a year of hormone therapy with the PROTEUS regimen versus 6 months in the salvage setting versus 2 years in the primary radiation setting? So these are the type of conversations that we need to have with our patients. And I don't think there's a one size fits all, but I think for the younger patient, our patients in their 50s and 60s who have an aggressive, high volume cancer, who are interested in prostatectomy as their primary treatment, I think that, this is a data-driven good consideration.
Thank you. So some data were quite astonishing in a positive way for me. One that is astonishing because it's simple data, we already knew it, but seeing it in a randomized trial with more than 2,000 patients randomized is still very useful. Is, for example, you had an overall death of approximately 15% in patients undergoing treatment who are older than 75. So I think this clearly claims not that patients who are older than 75 should not undergo treatment, of course, but maybe that some of them should have avoided it because they then, of course, die because of other reasons compared to younger patients. So I think this was a good example. And recently, the Stampede Group published a very interesting paper, I think, as some months ago they did for crib reform in another landmark trial. And retrospectively, having a look at the patient using digital pathology and AI, they were able to see, of course, that the benefit was substantial in terms of systemic intensification, was just substantial for a subgroup of patients. Does the PROTEUS include some biology analysis and some aspect of this personalized medicine pathway, but that I think will become the standard for treatment intensification in the future?
Yeah, there's a lot of power to the PROTEUS data set because it's 2,000 men underwent prostatectomy. And remarkably, we have baseline and prostatectomy slides on all but 2 of the cases. So there's going to be great correlatives that come out of this trial that to answer some of the questions that you're asking. Presently, I've seen some of the genomics and transcriptomics on a small subset of about 155 patients that were done before the unblinding of the exceptional responders and non-responders, but
which is probably one of the largest series, despite the small subset we have in terms of
Now there's funding to do 750 of the 2,000. So those analyses are underway, and I'm excited to see them. And, that PROTEUS is just a start. PROTEUS results are positive and good, but, I would say it's a first, a single or a double, right? Or, we have a long way to go. So what PROTEUS data can do is tee up hypothesis that, patients who appear destined to relapse or at high risk for relapse at the time of prostatectomy, we can now take other approaches. How the breast cancer data added on to, their initial work. So that's what excites me, is we can start with this backbone of ADT apalutamide, see how patients do, and then based on biology, have subsequent adjuvant therapies for those who appear to need it. So I think PROTEUS is a beginning. It's a big beginning, 2,100 in trial, a huge price tag, PET scans and central review of everything. And so we will learn a lot about PROTEUS to come. There is a sub-study of 400 patients randomized 3-to-1 to prostatectomy versus the PROTEUS regimen, which has a 3-year EFS endpoint, which will likely be presented at ESMO so soon. And that will be, additional supportive data in terms of at least a 3-year event-free. So there'll be a lot of PSA relapses in that.
You are discussing about the arm which has just radical prostatectomy as a comparator, right? Okay, correct. So this was one of the other things I wanted to ask, because of course results are eagerly awaited also in this sense, as the current standard of care is still radical prostatectomy.
And we, when we built the trial, I actually submitted it initially as an IST, and the control arm was prostatectomy. But the downsides of having an unblinded trial that was going to require long follow-up made it really impossible to do that as the control arm, because patients who unblinded, know they didn't get therapy on trial would just drop out, right? They wouldn't invest in getting the scans over time. I think while the control arm is not standard, it raises the bar. It's not like the RP switch arms in a lot of CRPC trials where the response rate is low. You're almost comparing your treatment to supportive care. Like, this is not that. This is raising the bar to how much better the experimental arm had to be to show a positive result.
Of course, it has to be difficult because it's like, in one sense, if you're in low or intermediate risk disease setting, if you compare, for example, focal compared to radical, you will have people wanting for focal. And in this sense, if you want people looking forward to treatment intensification, like maybe the best candidates to this trial, those are with a higher risk, as we said. If they know they will get less, maybe they won't get into the trial or they withdraw consent. So it's the opposite setting compared to the intermediate risk, and it's not always easy to randomize this patient to make them accept getting nothing if they know it. Another point, which is a bit more scientific, is that, of course, following FDA approval in 2022, I think, if I recall correctly, you implemented the use of PSMA PET to assess METs, which is, I think, can be seen in two ways. On the one hand, it makes PROTEUS a modern trial because now everyone is using PSMA PET. Of course, on the other hand, we know that PSMA PET gets disease a bit earlier compared to conventional imaging, so it can still be considered as a surrogate endpoint for survival on the one hand. On the other hand, it has not been validated as low conventional imaging. I think, again, this is something that says we are doing well because we are able to get disease earlier, and these are still men that have METs. As we mentioned earlier, there are lots of interesting secondary endpoints that are, I think, helpful to patients, getting, I think, 30% less radiation, having less events. So this is my personal opinion, it's still clinically meaningful. How do you position this PSMA argument within the context of PROTEUS, and how do you think results should be interpreted based on this limitation, if we interpret it again as a limitation of PSMA?
I don't interpret it as a limitation. I interpret it as a different method for measuring. Clinically, the only clinical meaningful image to get, right? Because it's what we use both to stage the patients before prostatectomy and if their PSA goes up after. And the other thing about PSMA PET, which makes me comfortable with it, is it's not like PSA, where when the PSA goes up, half the times we just follow the patients and don't do anything. When we see metastasis on a PSMA PET scan, we treat them. We do SBRT or
MDT.
combination of ADT and SBRT. I think it is measuring metastasis earlier, but it's measuring metastasis and not some metric of microscopic disease. So 70% of the patients in PROTEUS had PET because it wasn't available in all the countries. And the people who met MFS by PET had to stay getting conventional imaging every 6 months until conventional progression. So we'll learn a lot from it. And I hope that this is the first trial in which PET then becomes standard of care in early stage disease.
Yes, I used the word limitation, but that was not my meaning. My meaning was exactly what we discussed earlier. So, of course, you cannot not do it, but at the same time, when you do something which is relatively new, you cannot have long-term outcomes. So, I think it's inevitable to have these aspects within the trial, but I think it's one of the most important aspects that this has been used. I think it's the sole modern trial which uses it currently in the majority of patients. So I think we're going towards the end of the interview. One of the last question is towards the future, of course, because it's a revolution. How do you see the fields moving forward in the next years? Do you see it moving towards more drugs or towards better patient selection, or maybe both?
I think both. I mean, PROTEUS is a selection trial, as you pointed out initially. These are a subset of the high-risk patients. And then as the correlatives, roll out and we learn more about responders and non-responders, we'll be able to strategize more. So yeah, I think it's selection and having better tools. There were multiples of neoadjuvant trials done in the 90s and early 2000s with ADT alone and drugs like flutamide and bicalutamide that really didn't show any clinically relevant benefits. So the androgen receptor pathway inhibitors are a new tool that we have to use that is a more intensified disruption of the androgen receptor axis and able to get into the tumor tissue and prevent that mechanism of resistance, which is the tumor cells making their own androgens, at least for a while. I think we'll have better combinations. Drug development is really speeding up now with AI and other implications, and the new drugs in development, the ADCs and the bispecifics and RLTs, and hopefully we'll learn how to use them in patients who have early lethal prostate cancer.
Yes, as you mentioned, for breast cancer, it's maybe like use the right tool in the right patients. Unfortunately, in prostate cancer, we are always coming a bit later compared to breast cancer. At least this is my impression. But with these trials, we may be able to try to get them. To conclude, from my personal perspective, I think there are 2 or 3 main take-home message from the whole talk and from the study. To try to be very brief from my viewpoint, these are that in high-risk disease, local treatment is important, and of course, it has a role. The second point, I think, is quite important and quite relevant from the study, is that surgery has a role in the treatment of high-risk disease, which is what the trial clearly reinforces. And the third point is that we are improving, of course, but we're getting towards personalized medicine. And local treatment, surgery, and intensification is not a one-fits-all approach, but it has to be targeted, and we are in the era of personalized medicine. If you would have to give 3 or 4 take-home message from all the huge amount of work for which, again, I congratulate, what would you rather mention?
Well, I would say that neoadjuvant and adjuvant apalutamide and ADT reduce the risk of metastasis or death by 20 to 26%. And that improvement was supported by a reduction in all events and by a delay in time to next therapy of almost 3 years. I would say that we're making progress preventing and delaying relapse.
Okay, thank you very much. So we discussed a lot. There was also a lot of discussion in terms of is it practice changing or not. I would say the main point is, besides the fact it could be or not practice changing, is that indeed it is paradigm changing. As you mentioned, it's an enormous start Thank you very much for the nice discussion and for being with us. And thank you all for listening.
Thank you.
Thank you for listening to this episode of the EAU podcast. To keep up to date with the latest developments in prostate cancer, visit our educational platform, UROONCO Prostate Cancer. To stay informed about advances in urology, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.